Oh, there are people.
Hello, and good afternoon. Welcome. You're here with us for the UNC Cancer Network RN and Allied Healthcare Lecture. So glad that you can be here today on December 14th of 2016. This is our very final lecture of 2016. So we'll have lots of information which we'll talk about at the end of today's presentation on the 2017 lecture series. A few preliminaries before we get started and introduce our guests. If you are having any technical difficulties at all, you can find us on email at unccn@unc.edu, and you can email us any concerns you have. You can also email us questions which we can relay to our guests. You may also call or text us, either one at 919-445-1000, and our staff will get back to you with, again, any questions or concerns. Finally, we use a tool called Poll Everywhere for questions. You start by texting to the number 22333, the letters UNCCN. Once you've done that, you'll get a little text response back saying you're connected, something like that, and then you can text in your questions, including the first question that we have for you in just a moment. You can check us out on the web at unccn.org. You can find us on Facebook. You can find us on Twitter. So glad that you can be here with us today. All right, the poll, which we'll go to for real in just a couple of minutes, it says what exists in the cancer care system that can create bias and inequity. So your thoughts on what can within the cancer care system can create bias and inequity. It can be just a couple of words. It can be just one word, but something that you think causes bias and or inequity in the cancer care system. Again, you start by texting the number you'll be going to 22333 with the word UNCCN, not really a word, but the letters UNCCN. And once you've done that, then you can start texting in your questions. As we go through the presentation, you can text additional questions, and once the presentation is over, we'll see all of those questions, and our guests can answer those in the time we have for that. All right. With that in mind, I want to introduce our guests here today, and we'll start with Dr. Jeannie Ng, and she is professor at the Department of Health Behavior and director of the Cancer Health Disparities postdoctoral program at the Gillings School of Public Health, the University of North Carolina at Chapel Hill. So, Dr. Ng, welcome. And she has a master's in public health and a doctorate in public health. Maybe you can take just a moment to tell us about your background.
Well, I've been here for over 30 years.
Terrific.
Yes, at UNC. Got my degrees here, as well as now been teaching and doing research here. So it's been wonderful to really be a part of Carolina and to be part of the Lineberger Cancer Center. And my work is in community-based participatory research, and so it's a different approach where we are engaging communities who are the intended beneficiaries of our research to actually be the research partners. And today will be an example of that work.
Terrific. We're so glad to have you here today. I would also like to introduce Dr. Jennifer Schall, MD, and she is founding member and past co-chair and current secretary of Greensboro Health Disparities Collaborative. Dr. Schall, welcome. And again, if you could tell us a little bit about your background.
I am a retired OBGYN. I graduated from University of North Carolina at Chapel Hill School of Medicine.
Very good.
I practiced in Greensboro, North Carolina, and after retirement, I became increasingly involved in the work of the Greensboro Health Disparities Collaborative, and I now say that I am an accidental health disparities researcher. Not where I thought I'd be at this point in life, but where life has brought me.
Very good. We're glad to have you here. Thank you so much. And Beth Smith, RN and MSN, Patient Navigation Program Manager at the Cone Health Care Center in Greensboro. Beth, welcome.
Thank you.
And again, if you could tell us a little bit about your background.
I've been a nurse at Cone Health for 36 years and have done many roles as a nurse at Cone Health, and decided a couple years ago it was time to make a change, and there was the opportunity to become part of the ACCURE research study as the navigator, and that's what I currently do and enjoy very much.
Thank you. Thank you for being here today. The topic today is accountability for cancer care through undoing racism and inequity. And so with that in mind, I'm going to go ahead and turn this over to Dr. Shaw.
Thank you.
And, oh, you know what? I forgot to do something. If you would, and let me do that, because I did not look to see if we had any responses to our first poll. So let's see what we've got. And again, by texting to the number 22333, the letters UNCCN, and there we go. Lack of insurance and biased policy are our first two answers. And I'm guessing between the three of you, you may speak to both of those and many other issues as well. There you go.
Thank you.
Thank you.
Okay. The three of us are members of the Greensboro Health Disparities Collaborative, a community-based participatory research group that was established 14 years ago. This photo of the collaborative is early in our history. We had an 18-month planning grant that enabled the partnership project, our fiscal agent, and the University of North Carolina at Chapel Hill to deliberately select a multiracial, multi-ethnic group of community, academic, medically trained people of different ages from Christian, Islamic, and Jewish faiths to form this collaboration. Together, we completed the Undoing Racism training, and this training provided us with a common language and an analysis of institutional racism that has been essential to the success of our group as a community academic health agency partnership. Our mission, as you can see, is to establish structures and processes that respond to, empower, and facilitate communities in defining and resolving issues related to disparities in health. To provide a brief context for the Greensboro Health Disparities Collaborative, Greensboro is the birthplace of the civil rights movement, where 4 students from North Carolina A&T University conducted the first lunch counter sit-in on February 1st, 1960 at the Woolworth store on Elm Street. The building now houses the International Civil Rights Center and Museum. Throughout our history, the citizens of Guilford County have played an essential role in this nation's civil rights movement. It was also in Greensboro where several black doctors, dentists, and patients organized under the leadership of Dr. George Simkins, Jr. to prosecute the largest white-owned and white-served-only hospital in town at the time, Moses Cone Memorial Hospital, for discrimination by maintaining racially separate medical facilities with taxpayers' money. L. Richardson Memorial Hospital was the hospital reserved for black patients and staff. The history and the success of this case, which went to the Supreme Court of the United States, was documented in an article published in the Annals of Internal Medicine in 1997. The 1963 case of Simkins versus Cone Health decision marked the first time that a federal court applied the Equal Protection Clause of the 14th Amendment to prohibit racial discrimination by a private entity. The year after the Simkins decision, Congress passed the Civil Rights Act of 1964, officially prohibiting private discrimination in public places. The spirit and the passion of these historic civil rights movements in our city motivated subsequent residents to continue the struggle for equality, especially in healthcare. Since 2003, to join the collaborative and/or work with our studies, everyone must have completed a 2-day anti-racism training offered through the People's Institute or the Racial Equity Institute. The training introduces concepts and strategies related to community organizing and system change, while fostering relationship building through various activities. It challenges participants to analyze the structures of power and privilege that hinder social equity, provides a historical and institutional understanding of and a shared definition for racism, and it prepares participants to be effective organizers for justice. Having this common understanding about race and racism has allowed our collaborative to be more open with one another. We don't have to worry about being politically correct because we can be clear about any issues we discuss. This strengthens our understanding of one another, and it makes it easier to talk about difficult race or ethnic issues. Training in providing culturally competent care is intended to raise an individual's awareness of racial, ethnic, and tribal disparities. But this approach does not move us toward assessing and addressing the stark realities of inequities in our health care system, or for gaining tools to combat the inequities at the system level to move toward improving patient or client outcomes. Training in culturally competent care has been mandated since 2001, but it has not been working to change the persistent racial health disparities in our systems.
So, for example, the inequities that we're addressing now through the Greensboro Health Disparities Collaborative, despite decades of documenting racial disparities in cancer survival in the U.S., variations in treatment persist. African American breast cancer patients, for example, continue to initiate treatment later and are treated less completely than their white counterparts. Also, non-small cell lung cancer represents over 80% of all cases, yet 24% of white patients and 36% of African American patients with stage 1 or 2 disease and their physicians are deciding independently or mutually not to pursue surgical resection, which is the only reliable curative treatment with a 5-year survival rate of about 50% for localized and 21% for regional disease. So patients who do not undergo appropriate lung resection surgery are limited to a median survival rate of less than a year. This racial variation in surgery has been directly linked to excess lung cancer mortality. So to investigate why this is happening, we as a collaborative took the community-based participatory research approach, having now already established a common vocabulary, as Jennifer has described. And we decided to take this approach and therefore to address the structural issues that would enable partners to actually look all along the way from the research question to developing the methods to then submitting the application, getting the funding, and actually conducting the study to examine structural issues with regards to cancer disparities. So both the guiding principles of anti-racism and community-based participatory research, as you see here, helped us to learn more about the root causes of racial disparities in health outcomes and cancer care. So these principles that you see are the foundation upon which our partnership has been built. So we first, GHDC, our first research question was to do a formative study to see what was happening in cone health, for which there were these inequities in outcomes. So the question was, did African American and white women with breast cancer in Guilford County, North Carolina, receive treatment at Cone Cancer Center that was the same? If the breast cancer was not the same, if the breast cancer care was not the same, how was it different? And what could have been done? What could have been the reasons? So we submitted an R21 application to the National Cancer Institute and were awarded 2 years of funding. And then we applied the findings from that R21 to design a 5-year intervention study, and again submitted that to NCI. And we will be focusing on the 5-year intervention study. Just let me show you for the 5-year study of who all the partners are. So it's been funded by the National Cancer Institute as an R01, and it's a randomized controlled trial intervention research project. We began the study in 2012, and we are currently in our final year. It will end March 2017. So as you can see, the collaborative is engaged. We engaged the University of Pittsburgh Medical Center as a second site. So they are now, they joined the collaborative and for ACCURE serve as the second site. And this was enabled by one of our postdoc fellows at UNC, took a faculty position at Pittsburgh, and through his work at Pittsburgh, then introducing anti-racism framework and community-based participatory research, we were able to engage a second site in the Northeast, much larger than the Cone Health Cancer Center, and obviously Cone is in the South. So in sum, ACCURE involves community, academic, and medical partners in Greensboro, Chapel Hill, and in Pittsburgh. And the disciplines range from medical information technology, social and behavioral sciences, cancer advocacy, and anti-racism. So the ACCURE research question focuses on systems change, as I said, to enhance race-specific equity in the quality and completion of cancer treatment among early-stage breast and lung cancer patients. Our study design to examine the system change effects at the two cancer centers, we decided to use a prospective interrupted time series study design that included analyzing 4 years of cancer registry data from the two cancer centers by race to document the race-specific inequities in standards of care and outcomes before our intervention began. So this would give us a baseline, but over time period of 4 years. We also then are collecting prospective study from both cancer centers for all early-stage breast and lung cancer patients to monitor to see then after we've begun the intervention, has the slope changed and has the gap between white and African American patients gotten smaller. We're also have embedded in here with the nurse navigator component to test the effectiveness of the nurse navigator component. We have a randomized control trial where patients are assigned to the usual navigator or to our ACCURE navigator, who is Beth. So now this is the intervention. It was designed again by our collaborative to address two primary principles that arise from our training in anti-racism: transparency and accountability. The anti-racism framework posits that institutional racism in the U.S. has been created and enabled to persist because the system is not transparent about how it works and how it contributes to inequities. It's not transparent to the clients it serves, and it's not transparent to the workers who are employed or run the system. And the second aspect is accountability, and that systems do not have transparent mechanisms to actually hold themselves accountable or hold themselves accountable to the community for equity in healthcare outcomes. So you see here we have transparency components and trying to make it more transparent through the data that are being collected through the cancer registry already, through the electronic health record, electronic medical record system. But how do we analyze that data and use that data to actually document the inequities or equities that are happening there? So we've established a real-time registry, which Beth will describe, and then also doing an automated prospective analysis of using the data, the electronic data from both hospitals, and a power analysis. For the accountability components, we have established this position of an ACCURE navigator who's specifically trained to work with patients one-on-one, but actually to work with patients to see how the system is working, to make it more transparent, and then if there are inequities, of helping the system to be more accountable for it. Clinical performance reports is another accountability mechanism whereby we actually then aggregate the data and then present the findings to the clinical staff And we do this every quarter. And it's delivered by, we have an ACCURE physician champion who delivers it to the clinicians. And then finally, we've been conducting healthcare equity education and training for all the staff, not just the clinical, but all the allied health staff, the receptionists, social workers, to report on our findings and then to also introduce the anti-racism framework. This is just kind of a snapshot of the kind of outcome data that we are collecting, how we're creating the variables from the electronic medical records. And these here are the definitions. And then this is for the prospective study that we monitor to see if there are changes in these outcomes. Okay.
Okay. Multiple parts of the ACCURE intervention were begun simultaneously, but the first component to be completed was the power analysis of the cancer care system at each site to find the pressure points within the system of care that either encouraged or discouraged patients from continuing their care to completion. ACCURE's power analysis utilized focus groups to develop an analysis of the power structure of the cancer care system from the perspective of the patients at our 2 cancer centers. The information that was gleaned from these focus groups is being incorporated into the Healthcare Equity Education and Training Workshops, or HEAT, as I may refer to it, for providers and staff at these cancer centers, which is an accountability component that we're going to talk about more later. In the Undoing Racism curriculum, the power analysis is a tool that's used to encourage participants to examine structures of power and privilege that hinder equity in all of our systems, not just cancer care, but in all of our systems. In ACCURE, we have adapted this tool to utilize the knowledge and the expertise of the patients and the healthcare workers to analyze the structure of their specific healthcare system to focus on systemic issues that hinder equity for patients within that system. A diagrammatic representation, as you see on this slide, is developed to illustrate the relationship between the many systems that interact with, in, and upon communities. We adapted this metaphor to ask patients to address how the various components of the cancer care system affected their decisions about continuation of care. In order to have a visual tool to assist in our focus groups, community, medical, and academic members of the Greensboro Health Disparities Collaborative worked with breast cancer survivors from the Sisters Network Greensboro, which is a local chapter of a national African American breast cancer survivorship organization. So we worked together to develop a visual representation of the cancer care journey, which served as a template for the development of our power analysis. The development of this diagram itself was a community-based participatory research process. And I want to briefly talk about this diagram and its components. As you can see, the journey begins on the left side of the diagram in the community, where the patient first either had suspicion of cancer or, as you see in that first box on the upper left, a diagnostic test that revealed their cancer. The journey ends on the right with the patient follow-up and their return to the community. The intervening journey can result in interactions with multiple parts of the cancer care system, as seen in the center boxes. The top center box talks about the surgical experience. There are arrows then down to the left, radiation oncology, down to the right, medical oncology, and then in the center part, the oncology center itself and the different components and parts that patients may encounter within that system. And then up on the upper right, we have other experiences that and encounters that patients may have within that system. So utilizing this diagram, we conducted 8 focus groups with cancer survivors from the 2 cancer centers. They were grouped by race and by cancer type, so black and white focus groups and breast and lung cancer focus groups. The focus group guides were developed by a group of volunteers from the Greensboro Health Disparities Collaborative that included academic and community partners. The questions on the guide were initially based on information that was gleaned from our first research project, SIMKINS, Cancer Care and Racial Equity Study, with additional input from Sisters Network members. The focus of the questions was to understand systemic barriers and facilitators, again, that either encouraged or discouraged patients from continuing their planned series of treatments for their breast and lung cancers, as you can see from the questions listed here. Once we identified the pressure points encountered by the patients, we used the cancer journey map to visually pinpoint where in the treatment journey these had occurred. As you can see from this kind of messy looking diagram, that there were many instances of positive encounters, which you see in green, negative encounters, which you see in red, and then the yellow arrows indicate either neutral or situations where there were positive and negative encounters within the system. This visual map was very useful in pointing out places where the cancer system, in the cancer care system, where patients have both positive and negative encounters, which affect their decisions about continuing their treatment. We subsequently used the same diagram to discuss with the cancer center staff where they felt that the pressure point encounters occurred during one of our healthcare equity education and training, or HEAT, sessions. The cancer survivors who participated in the focus groups expressed positive experiences with the cancer center as a whole. They said they did not feel that they were treated differently by race. However, when we looked at the power analysis findings, we found subtle distinctions in how the African American cancer experience, their cancer treatment experience, compared with the white patients. This slide summarizes the findings from our power analysis, as was indicated on the map that you just saw. This slide focuses on the experiences of the black patients. There were both similarities and differences in between the two cancer centers. Similarities include communication challenges, delays at various points in the cancer care journey, and problems with pain and side effect management. Differences include flexibility regarding treatment and perceptions of the provider and staff attitudes. We are using these findings to inform our healthcare equity education and training, or HEAT, sessions as a foundation for system-level strategies to reduce gaps in cancer treatment and outcomes at the two cancer centers. The HEAT sessions have been modeled after the Undoing Racism curriculum. The Undoing Racism curriculum is a 2-day intensive interactive dialogue and learning experience, which includes 5 phases that we adapted to ACCURE's HEAT format of 8 one-hour sessions that were delivered quarterly over 2 years. Our first session began with an exercise in shifting the paradigm of how we look at the causes of differences in health outcomes by showing the video Bad Sugar from the Unnatural Causes series on how damming the Gila River in Arizona resulted in a massive increase in diabetes in the Pima Indian tribe. The second half of that first session, we examined the historical and current relationship of institutions and communities and presented our 7 years of retrospective cancer registry data from each of the cancer centers on race-specific standards of care and showed a visual description of the power relationships within each cancer center. To some extent, these sessions were tailored to match the personalities and opportunities that were present in each of the cancer centers. Our second session discussed the concepts of gatekeeping and accountability and internalized racial oppression, and presented and discussed findings from the focus group interviews with current patients to show race-specific pressure point encounters in each cancer center system for managing treatments of side effects and pain. And again, these were tailored to the different cancer centers. The third session focused on examining and defining manifestations of implicit bias within our institutions, linguistically, culturally, and individually. And the fourth session presented preliminary findings on the patients who were enrolled in the ACCURE randomized controlled trial on quality and completion of care by race. The fifth session, we reviewed gatekeeping, during which we presented and discussed findings, again, using examples from the specific focus group interviews to identify examples of gatekeeping within the cancer care system. In our sixth session, we focused on identifying how the institutions impose their values and their culture on the communities that they serve, and reevaluated this in relationship to implicit bias. In the seventh session, we examined the findings from our retrospective and our prospective data on quality and completion of care by race for all patients served by the cancer centers. And in our final session, we discussed strategies and tools for sustaining the ACCURE intervention components. Here are a few quotes from the participants at each cancer center to the open-ended question, in what ways do you plan to use the information presented or the ideas from the discussion to improve the outcome for your patients? Now Beth's going to talk more about the navigator component.
As previously mentioned, the ACCURE study has both transparency and accountability components as seen in this slide. ACCURE's informatics intervention component developed a real-time registry to signal me as the nurse navigator about missed appointments and deviations from the standards of care. This information helps me to intervene and have better communication with patients and providers to keep patients on track to receive expected care. The race-specific information gathered through our real-time registry is being incorporated into clinical performance feedback reports for ACCURE's physician champions to deliver to clinicians at each site. I'm often asked to explain the role of the navigator. In order to create consistent care, all the navigators at the Cancer Center met to establish standard navigator activities, accepting that 80% of all navigators' work is consistent and 20% varies based upon the patient population and acuity. These activities are listed on the next few slides, and I will highlight just a few of those. The navigator will collaborate with a multidisciplinary team to coordinate care to obtain a diagnosis in a timely manner. The collaborator will make necessary referrals to appropriate members of the multidisciplinary team, for example, physical therapy, palliative care, speech therapy, nutrition, clinical social work, and to survivorship. The navigator facilitates the multidisciplinary clinics that occur every week for every cancer site. The navigator will ensure that the patient's initial plan of care, as discussed in the cancer conference, progresses in a timely manner. For example, she will follow up to make sure that schedulers have scheduled appropriate appointments, that physicians and physicians RNs have entered appropriate orders, and that appropriate referrals have been made. The navigator will make contact with the patient at the time of or within 1 week of initiation of treatment. The navigator will follow up with the patient at completion of treatment or within 6 months. And then once the treatment has begun and during active treatment, routine care, which includes symptom management, referrals, scheduling and ordering tests, and procedures, will be managed by the physician's nurse unless assistance is needed by the navigator to remove barriers. In addition to having completed anti-racism training, participating in the Greensboro Health Disparities Collaborative, and the use of the real-time registry, one thing that distinguishes the ACCURE navigator role from these usual navigator activities is more frequent proactive patient contact and communication. The role of the usual patient navigator has been one of a more reactive posture, responding to expressed patient concerns, usually after non-adherence or omissions in care. The ACCURE navigator role is a more proactive approach at the outset of care, establishing communication protocols not only to solicit patient understanding, but to specifically address questions or concerns raised by the patient before a break in care occurs, before an appointment is missed, and before patient care milestones go unmet. In the ACCURE protocol, patients receive 2 face-to-face sessions. They are provided with the navigator's contact information, and they receive telephone calls every 2 months. If the patient is a no-show for a scheduled procedure or appointment, the ACCURE navigator will assess for mechanistic barriers, and if there are no mechanistic barriers, will assess for fear. If fear is not a factor, the navigator will assess for trust issues, disbelief of diagnosis or the potential diagnosis, perceived disrespect, perceived racism, or any other barriers that may have influenced their noncompliance. The real-time registry enhances transparency about a cancer care system's equity and quality and completion of care by monitoring a patient's adherence to appointments as well as the system's function and having the patient reach milestones of care. To establish the real-time registry, we defined variables with each cancer center's IT specialist that could be pulled automatically from their respective cancer registry and electronic health record system and then compiled into a report. SHEP's integrated research system is used to track study participants, to prompt staff for patient follow-up, to generate reports, and allow direct key entry of patient information. This accomplishment is directly responsive to the Affordable Care Act's mandate for the meaningful use of data. The ACCURE navigator is another component that enhances accountability for equity and quality and completion of cancer care. If a patient misses an appointment, then the emphasis is on serial communication and re-engagement of the patient. This is where exploration of all types of barriers occur. If a patient is keeping appointments but not reaching milestones, then the ACCURE navigator accountability involves approaching the caregivers in the system to explore reasons for the milestones not being met. Given cancer care knowledge and the hierarchy of the system, the navigator is not always empowered to directly engage providers, so physician champions partner with the navigator to serve in this accountability role. The real-time registry reminds navigators to have a proactive approach to communication with patients. Here is one patient encounter. So what happened? The patient attended a breast multidisciplinary clinic where she met her medical oncologist, her surgeon, and radiation oncologist in one day. During that appointment, she received her treatment plan, which included starting the patient on a neoadjuvant anti-hormone therapy, or letrozole, before surgery. The ACCURE navigator received an electronic warning from the ACCURE real-time registry to give the patient a follow-up telephone call after the clinic appointment. The ACCURE navigator documented the following note about her intervention. I called the patient to follow-up breast multidisciplinary clinic on 6/11/14. Patient reports that she is doing well. She completed her scheduled MRI this AM. We reviewed her scheduled appointments. She had a conflict with an appointment requested by Dr. Y. She also reported that she had not started the letrozole because her pharmacy said they were waiting on authorization. I followed up with Mrs. Z, who obtained Aetna approval. I also rescheduled patient's appointment with Dr. Y. I called patient back with these updates. Patient verbalized understanding and denied any other questions or concerns at this time. I gave her my contact information and instructed her to call me for any needs. In this example, the ACCURE nurse navigator identified 2 healthcare system barriers. They were barriers resulting from the healthcare system controlling appointment scheduling and the healthcare system policies and medical staff workflow. With this automated meaningful use of data, ACCURE's nurse navigator and the physician champion are enabled to serve as advocates for the patient, not just advocates for oncologists and surgeons, by interacting with each patient in real time and amplifying their voices at organizational meetings with clinicians. They serve as planners and promoters of healthcare equity, education, and training for all cancer center employees, clinicians and non-clinicians alike. Finally, they are partners in interpreting data from the real-time registry and prospective data sources and disseminating the findings to cancer center providers. The role of physician champion has been important to help inform their colleagues about the importance of the study, to share feedback on performance, and to gain participation and support from providers. They are available as a resource to the navigator, not only for their clinical expertise, but to assist in following up with providers when patients miss milestones in care.
You might want to hit it again. There's animation, yeah.
Oh, sorry.
So now we're going to just kind of share with you some initial findings. Because we are in our final year, but we're continuing to analyze our data, and we also, because of the community-based participatory research approach, we wanted to present the findings to our participants first, the cancer patients who participated, who were part of the study, and then also certainly to present it to the staff and the clinicians at each of the sites. And then to have a community forum in Pittsburgh as well as in Greensboro, and of course working on manuscripts, etc. But these data, we're going to show you our preliminary findings about just the lung cancer component. We achieved parity, actually, that narrowed the historical racial gaps in treatment, and at the same time raised treatment completion rates for both races. We had compared race-specific rates of completing potentially curative treatment, that is the surgical resection, within 4 months of diagnosis. You can see that at baseline patients, there were 2,044 baseline patients at both cancer centers who had received treatment between 2007 and 2011 before ACCURE began. Then for ACCURE, 393 patients were randomly assigned to the usual care navigator, and 100 patients were randomly assigned to the ACCURE navigators at both sites. So this table shows you that among the baseline patients, we found a significant racial gap of 75% white versus 64% African American who had received potentially curative lung cancer treatment. That's before we started the intervention. You can also see, though, among patients who had been assigned to the ACCURE navigators, there was an 11 percentage point racial gap that disappeared. 95% of both white and African American patients completed potentially curative treatment. Among the usual care navigator patients, we also saw a significant improvement when compared to baseline. In completion of potentially curative care, 87% of white and 85% of African American patients during the study period. So this finding may be the result of a likely spillover effect at the two cancer centers, whereby the ACCURE navigators' sensibilities and training may have influenced staff outside of this particular project. So.
One of the things that we're very proud of in the Greensboro Health Disparities Collaborative is the way in which we've had community involvement throughout the ACCURE project, not just on paper. It is real and substantial. As you can see from this list, the Sisters Network members were involved in editing the interview script for the controlled trial, interviewing the candidates for navigator positions. We felt it was very important to have community input on selecting who would be the navigators for ACCURE. And then in providing informal consultations about the process. At various points during the study, we have consulted with Sisters Network members about process and procedures. Greensboro Health Disparities Collaborative members, in addition, were involved in the design and application for the grant, in writing the interview script, in developing the focus group guide, in coding and analyzing the focus group data. I don't think I mentioned this earlier, but one of the components that we feel is very important when we're doing both the coding process and the analysis process was to have community and academic coders involved in looking at each transcript, and people of color and white people involved in looking at each transcript. And then after that initial analysis, taking it back to, again, a broader group with academic community, people of color, white people, so that we were getting multiple viewpoints on our analysis. Greensboro Health Disparities Collaborative members were responsible for interviewing the patients enrolled in the controlled trial, and 2 active members were always involved in the steering committee process. Our steering committee met weekly throughout this grant.
Right. So, thank you.
Thank you.
Yeah.
Right, and thanks to all of you. I really appreciate this. This is incredible work. Obviously, you're saving lives and making a tremendous difference in lives. If you would pass me the keyboard, please. And we'll go ahead and take a look and see what questions we may have. Just a reminder, if you do have questions, you can go ahead and email those at unccn@unc.edu. You can text or phone those in at 919-445-1000, or you can, if you haven't already initiated the poll everywhere, do that by taking the number 22333, and you're going to send the letters UNCCN, and that'll start you off, and then you can send your questions in. Let's see what we have so far, and I know I've got a few as well. So none yet. So please take this opportunity to get those questions in. And while we're waiting for those to come in, I know I've got a few. The workshop that you talked about sounded tremendous in terms of the different pieces of that. And I was wondering, are there particular elements to that workshop that were transformative, or where you saw kind of aha moments? And if so, what some of those might have been?
Well, since I moved from being a practicing physician to doing health disparities research, I would say that the anti-racism workshop has been transformative in my life. And I think that what to me is most important about it is the view of how systems function and the relationship of white people and people of color to systems, and the differences in that, and how that affects everything about how they can move through their lives. And trying to take that analysis and applying it to one specific system is challenging, but I think it's enriching. It has really helped focus our work, and it helps the people within the collaborative have a real mission, and I think that strengthens our work.
Are there particular? Do you see particular situations or steps along that path where people become receptive and are starting to make that shift, where they're maybe having the ability to see things that they may have done in the past that were not truly in the best interests of their patients, and where they might? I guess I'm trying to understand where they might make that shift to being more self-aware.
One of the sessions that we focus on, and for me when I first went through the training, is on being the gatekeeper, and not realizing that I was a gatekeeper. And I think for many of the nurses and social workers and physicians who went through our HEAT training did not see themselves as a gatekeeper, and then to have discussions about who owns the gate, and so that the bias or the inequities that happen may not be on you as a gatekeeper, but on how the system wants you to function as a gatekeeper. And so even having the power of deciding who gets the bathroom key makes you a gatekeeper.
Right.
Because in terms of access to resources. So it's not just power decision making, but any kind of resources. And that enabled us to have, I think, more of a frank discussion with them during the workshops, especially I think it was during the last workshop when we finally, I think there was enough trust and rapport built to be able to be more self-reflective and to know that the bias that is being seen by patients is not intentional.
Right.
It's just so implicit, you're not even thinking of it. And so we've been now moving forward to ACCURE 2, because that's what we're working on now, is the next 5-year grant based on these findings, is how do we remind ourselves? And so how will doctors have a card? Will nurses have a card? Each person, the receptionist, to remind themselves, am I actually using implicit bias here that I didn't have?
And how do you make that then a lasting transformation so that that's not, okay, I've attended the workshop, I've learned that, but
right,
that's
check.
checked, and but maybe not check, and then, but
yes.
how do you really maintain that?
And we're trying to really say, because cultural competency training, which is mandated, by the federal government, is a check.
Right.
You have medical school, you have to go through it. It's just a few hours. And but then we're saying, how arrogant is it to think that one can be competent in somebody else's culture?
Right.
It's a process.
Sure.
And you can't just learn it, in 30 minutes. And so that's what we're trying to bring into this. It's a systemic issue. Yeah.
This is really impressive. I see we do have a question. Why do you allow recruitment by invitation only according to your clinical trials .gov site?
Why do you only allow recruitment of the participants?
I guess our viewer who had texted in that question, if you have any follow-up in terms of who you're indicating in terms of recruitment, you can go ahead and let us know.
If it's of participants, Beth can talk about that. It's not by invitation.
No, it's not by invitation only. Recruitment with each cancer conference where new patients are presented, I would look at those patients and look to see if they met certain criteria for the study, and if they did, I approached each and every one of them to ask them if they would be willing to participate in the study, and that's how they were enrolled.
Right. So they could refuse us.
That's correct.
Right. And we definitely tried to over-enroll more patients of color. If that maybe that's if the person's going to respond, if that's what it means. Okay.
And here, I'm not sure if this is the same person. How do you account for things that are not necessarily race-related but prevent treatment? Like if someone hadn't started treatment because they didn't, and they may have been cut off, so hopefully that person will share the rest of their questions. And I know there's a limit on how many characters you can submit, so I'm not sure if they were cut off by the character limit, but if you please go ahead and share the rest of that.
Didn't have a
ride. Okay.
Well, what we did is we worked to try to secure a ride, but first we have to have the conversation with the patient to determine what really was preventing them from coming to their appointments or starting their treatment. That was part of what the intervention was to talk to the patient and just determine what exactly was causing their not following the usual treatment plan, and then to intervene. So there were many times that I arranged rides for patients because that was part of their problem.
But one could also, in terms of looking at why do some patients have more problems with transportation to get to the cancer center? Because you do have to, it's not on an easy bus route to get there. It's not downtown, and I know from. And so one can look at SES and income. Maybe you don't have a car. and that you depend on public transportation or a good friend or family, and why are those typically more likely to be patients of color, and to live in certain neighborhoods of Greensboro, which tend to be where the patients of color live, and so it's the entanglement of race with poverty or race with income is just very, very difficult to disentangle. And that's why, in terms of taking a systems approach like this, we can say don't have a ride, but how does that system work so that certain people are always having problems with getting a ride?
Absolutely. Here's another question. Have you looked at cancer outcomes with minorities, with black versus white doctors, and I might add with clinicians across the board?
Yeah.
Well, we didn't specifically look at that, but it has been looked at, and the issues that we're dealing with have to do with systems and how systems functions, and all of the caregivers within our systems are trained within that system, function within that system, for that system. And so, what has been shown when people have looked at this is that the same kinds of issues arise with caretakers of color and white caretakers. There are some differences, but the color of the physician or the nurse does not change the way in which the patient experiences the system. It may change in a specific encounter, but not how their general experience.
All right, thank you. Other questions that you have? We've got just a minute or two left if anyone else would like to share one more question with us. I was impressed by
or a comment.
Or a comment, yeah, absolutely.
What do you think about our project? Yeah.
Please. I was impressed with the real-time registry, and I know that I've been seeing some other work across the board in terms of this sort of approach. We're used to this when companies are trying to sell us products and getting reminders and getting to know us, but it seems like you're using that technology extremely effectively, and it was nice to see the interaction and how simple misunderstandings or lack of communication can be clarified to the patient's advantage.
I know that the two cancer centers they're thrilled to. But this is ahead of the curve.
Oh,
for them,
they are,
right?
Yes.
That we've already developed this real-time registry for them. And I must say the informatics for ACCURE took a lot longer than we thought to make sure that it was developed. So the software, because one hospital was just transferring over to Epic, and that was a nightmare, of getting that to do. And then other places where billing uses a different software from pharmacy, and so to get all that together. So.
Yeah, one of the things that I know I keep having conversations about is once these things are developed, how do we then take that and expand on all that wonderful work, and there's a lot of work there to do it, so that every other institution that wants to benefit from that doesn't have to recreate the wheel. But are you looking at ways that other centers can expand on this work?
For scaling up. And that's why we have these two cancer centers, one medium-sized, one large, and if it worked in both. And so our next, then it means that we potentially could scale it up. Currently, we're adding on another site that serves Latino populations, because neither Pittsburgh nor Cone in North Carolina has a significant Latino cancer patient population. And to see if this real-time registry and the Navigator and all that will work in the Southwest at a cancer center with that population, to give us even more evidence that this could be scaled up, and the software, all of that could be transferred over.
That's great. And if we have listeners in our audience today who are interested in finding out more about that, may they contact any of you? Is there one of you who they should reach out to? All right, great. Well, I see the healthcare system is all about money. This is a comment: the disparities in healthcare reflect the same in other parts of society. Any responses to that comment?
Well, I think absolutely. I mean, what we are saying is that there are similar inequities in all of the systems. We have chosen to work within the healthcare system and see if we can actually intervene and make a difference using our anti-racism principles.
Yeah.
But any other system, the same thing.
And they call it, they don't call it disparities, they call it a performance gap, you know, in the school system, for example. Yeah.
Well, I'll echo this last comment. Thank you all for your time. And I would add expertise and dedication, and this is wonderful work that you're all doing. We're so appreciative that each of you joined us here today. I want to just, I do want to mention we have, if you found this lecture meaningful today, I encourage you to look at a lecture that we had on one of the Med-Surg lectures a few months ago, and that was a Med-Surg oncology lecture, Health Disparities and Cancer Outcomes, with Dr. Stephanie Wheeler. And I think that she also, in a different way, addressed some of these issues, and that's one that I think that you will find meaningful as well. To close, I want to remind you again that at unccn.org you can find all sorts of resources. In about 24 hours we'll have this lecture online if you'd like to view the recording or share the recording with colleagues. So lots of resources there. Our 2017 lecture series, we've been working hard on that, and most of that is posted for the next year. That includes our Med-Surg, our RN and Allied Health, our Community Lunch and Learn series, and our new Community College series. And so we've got lots of information about all of those there. Here are just a few. January 11th, we've got RN and Allied Health using genetics and genomics for cancer risk identification. And then on January 25th, sickle cell disease, an overview and updates. That's our Med-Surg series. On January 27th, Community Lunch and Learn series, Clinical Trials 101. And on February 8th, our RN and Allied Health series, Late Effects of Cancer Treatment Managing Cardiac Toxicity. So just a smattering of the many lectures yet to come. We want to thank the generous support of North Carolina and for the University Cancer Research Fund, and we want to thank the UNC Lineberger Comprehensive Cancer Center. I would like to thank Mary King, our operational coordinator, Max Gaynor, our AV support engineer, and Alan Brown, our continuing education specialist, for all of their hard work to make these events possible. We hope that you have a terrific rest of the week ahead, and thank you so much for joining us. Dr. Eng and Dr. Shaw and Beth, thank you all so much for being with us today.
Thank you.